No, it's my absolute privilege and pleasure to introduce and chit-chat with my good friend Dr. Sanjiv Haribhakti, a renowned GI surgeon from Ahmedabad, Gujarat, and a multifaceted personality. He is an author, he is a researcher, he is a sport enthusiast and a spiritual person. Late. He's come to Chennai to attend a conference, accompanied his wife, who's an eminent ophthalmologist, and then I could just grab him to come to my home and chit chat and welcome to Chennai. And we worked together in the All India Institute many years ago under Dr. Professor Nandi, and that's how our association started. And we've been in touch and meet often and share our personal progress. If I can ask you to start with, you must be obviously one of those good students in school, and what made you take up medicine as a career?
Yeah, thanks Radha. At the outset, I must thank you, and it's an honor to be here with you and spending some time with you at your home. During the school, I mean, I wouldn't say that I was one of the brightest chaps in the school. Till the 10th standard, like I was a mediocre student. Maybe out of the class of 60, I would used to get a rank of around 20. The reason for going into or choosing the medical profession probably was in the family. We come from a family where there were many doctors who were like role models for me. My father himself is a dermatologist who is still active at 85 working. And my late uncle was a great human being, very prolific surgeon. Way back, he did his FRCS in 1947, and then he was working in Ahmedabad. So we used to, right from childhood, we used to see how doctors are respected as a professional, and what a kind of noble profession it is. It gives us an opportunity to serve people and to help people, to relieve them of their miseries and pain. So that was one of the motivating factors for me to choose the medical profession. And then after the 10th standard, I really became more studious and started getting better and better marks, because obviously medical profession was at the peak at that time when people had only with very good marks. Even today, they can land up in the profession. So then fortunately in the 12th, I could secure good marks so that I could get into the medical profession.
So effectively it's the parents and their kith and kin are the ones who, and how was your, where did you do your MBBS, which college?
My MBBS and MS was from Ahmedabad. This was an NHL Medical College affiliated to VS Hospital, where I did my postgraduate and masters in surgery from Ahmedabad.
And you have any good teachers to remember during MBBS, or someone who inspired you to? Your father is a dermatologist, but you became a surgeon. But in general understanding is that the specialty also comes as a hereditary thing.
Yeah. So when I joined the medical college, I was very clear that I'll become anything but a dermatologist, not a dermatologist.
Why?
Because somehow inside me, I had a feeling that I want to stand on my own feet, and I want to develop my own identity. That was the feeling that I always had. So then I thought that it's better not to be a dermatologist and to pursue a different specialty.
Right. No, but who inspired you to take up surgery as a career?
Yeah, my late uncle, Dr. Haribhakti. He was a great human being, a philanthropist, a great social reformer, and a great surgeon. He was, he almost practiced from 1947 to 1989 when he passed away. So he didn't see the laparoscopic era, but he practiced in the era where general surgery was like developing, right, from antibiotics to antisepsis. There was no specialization. They used to do neurosurgery, they used to do orthopedic initially, and then he used to do urology, GI, everything. They used to do burr holes, open the chest. So that was a time when general surgery was at the peak, and he practiced during that era of open general surgery. So he was the source of inspiration.
Do you remember any magnetic personality in the department of surgery in your medical school who sort of impressed you considerably during your training in general surgery?
Yeah, during my general surgery, we had good teachers in our department, in our medical college. However, this was an institution where there was a, an honorary system, that there was partly a private practice and partly they used to come for the institution. So there were very few people who were like very dedicated teachers or, very enthusiastic. Most of the learning was student driven. We had to do the learning ourselves. There were people to guide us, to take classes and to take lectures. And that's how one of the professors I remember was my professor of cardiothoracic surgery, where we used to go for rotations to specialties. And he also always used to tell me, because I had always this dilemma whether to do cardiothoracic surgery, which was very glamorous at that time. Cardiac surgery, bypass surgery was in the development, on pump and things, heart-lung machines was the in thing at that time. And GI, because endoscopies was there was no laparoscopy at that time, but because flexible endoscopies had just come in, there was a lot of glamour in GI and cardiothoracic surgery. And he used to tell me, I remember his sentence, and he still visits me as a patient, and I still remember that statement that he had made. Whatever you do, he told me, whether you do a hernia or you do bypass, you do it well. That is important. It's not necessary that because you are doing a bypass surgery, you are a greater surgeon, and because you are doing a hernia surgery, you are a smaller surgeon. Those kind of distinctions are there in our mind. However, whatever we should do it well. So that was something that clicked in me at that time, and I thought whatever specialty I take, I must do good justice to it.
So after general surgery, what did you do?
So after general surgery, as I said, this was the first dilemma. Like everybody else, I passed general surgery in 1992. I remember April was the time when I passed general surgery, and then it was like a sudden vacuum, which a lot of people like us face. Though masters in surgery is like a master's degree program, but we all face what next, what to do, because till that time the only goal is to pass MS. But after that, you are suddenly in a pool where you don't know where your life will take you. So I decided that I want to do GI surgery. At that time, the reason for choosing GI surgery was it was a very variety of organs, variety of diseases, variety of surgeries that used to enthuse me. And flexible endoscopies was something that was there, so that was something that I was interested in. And so once I decided to become a GI surgeon, then I started doing research. At that time, of course, there was no internet, and the only way research could be done was...
If I can interrupt you, see, the GI surgery was not an established specialty by then, especially
right.
in the western part. For that matter, the MCH course in Delhi came in 1994. What made you, did you come across any big time GI surgeon or somebody inspired you? Because how do you know that a specialty of that sort exists and there's a center there?
So fortunately, where I was trained for my general surgery, we had a department of GI surgery.
Really?
Right from 1984, yes, right from 1984.
Okay.
1985 or maybe 86, they started a department of GI surgery. Late Dr. Amrish Parikh, he started the department. And I worked in the department for almost 6 months, and I got interested in GI. I felt that it's a good field to pursue the,
and they are doing something more than what general surgeons are doing.
Yes, they used to do shunts at that time. Okay. They used to do corrosive strictures sometimes. They used to do, all the major cases. Of course, there was no laparoscopy, but they used to do ERCPs, endoscopies. Oh. So that is something that I enjoyed doing. And then I thought that GI is a specialty, because I also thought that cardiothoracic is an institutional surgery, and GI is something that we could do in a smaller setup. We don't need a very large hospital, or we don't have to be affiliated to a hospital all the time to pursue or practice our field of surgery. So that was one of the things that was in my mind, that I could practice this in a smaller setup, which could be, by a doctor or a group of doctors holding the kind of a private practice kind of a model. Because at that time there were very few academic institutions in our part of the country where we could devote our lifetime to.
So what did you do after MS?
So after that I started researching, and I identified that All India Institute Medical Science GI Surgery is one of the very good places for training. They have a dedicated department. Then I found out that GB Pant in Delhi also has a dedicated department, and I heard that SGBGI Lucknow is one center of excellence where GI surgery and MCH program has just started. So I went on a tour actually after my MS to visit these departments, and I met the people. And I remember one incident The moment I had entered AIMS, I met one of the residents who was working in the Department of GI Surgery at All India Institute. His name was Dr. Vivek Kohli. He's currently in the US as a liver transplant surgeon. And I met him and I asked him, how is the department, what is the kind of work you're doing, how much is the residents, how much work do the residents get? Typical question that we all ask. So he says that he told me two things. One, this is the best department in the country if you want to become a GI surgeon. And number two, it is almost impossible for someone outside All India Institute to get into this department, because so far in the history, only people from AIMS have got into this department. So I took this up as a challenge for myself. I said, let me take it up as a challenge. If nobody from outside AIMS has ever entered the department, I would like to take it up as a challenge. So then I met Dr. Nandi, and he was kind enough to allow me to start as an observer. So initially for 2 or 3 months, I was an observer. There was no position, there was no stipend, there was no accommodation, but I just worked like a regular resident, almost like 16, 18 hours a day, because that was the kind of work pressures. Very busy department, very sick, very complicated tertiary referral cases. So this went on for almost 2 to 3 months when a senior resident post opened up, and then I had to appear for the departmental exams and the test, and then I was selected as a senior resident. So that's how I could make an entry into the All India Institute.
But by the time you had visited other centers as well?
Yes, by that time I had gone to SCPGI Lucknow, and it looked to me like a dream to work in a place like that, because it's such a fabulous institute. At that time it was just newly built and a fabulous infrastructure, a very good department, dedicated department, and I just fell in love with it, and I thought that it would be a dream for me if I could get into this department. So that was my ultimate goal. Even when I was in the All India Institute, my goal was to get into Lucknow. So for that which I started preparing, because their exams would come in the December for the course starting next January.
So how long did you spend your time in the All India Institute? How many
So
years?
in All India Institute, I spent 2 years, 92, 93, and I was very fortunate, almost 1.5 years. I was very fortunate to have an association with many good, fantastic fellow colleagues. Dr. Radhakrishna was one, and I still remember that he came after he has finished his MCH for training in the All India Institute. He had done his MCH from MMC Madras under Dr. Rangabashyam, and I still remember that I was so naive, and I used to learn a lot from him about the intricacies of GI surgery and and insights. But the department has a very strict hierarchical system, and that's why even though he was much more senior to me, even then the departmental hierarchy wise, there was a difference in the way we were treated, but he took it very well in the correct spirit, because he was so grounded and so humble, and so we gelled across very well, and he helped me to get over these kind of competitive exams that I was giving. And I remember one incident very clearly, that the department of AIMS would not probably like, as residents we go out, and this is, I'm sharing something which has been close to my heart, that they didn't used to like people sharing or going to different other colleges, and that's why I had gone to Delhi University to give a MCH entrance for GB Pant, and I was on duty on that day in All India Institute, and I had requested Radha to keep the pager and do my call, and it was very nice of him to do that call, and I went to Delhi University on a scooter, on a two-wheeler, 25 kilometers one way,
Okay.
and I reached, gave my exams, and I came back.
Wonderful.
So I remember that incident very vividly.
See, what did you learn in the All India Institute other than operative surgery? What is it that you learned which still holds good in your career today?
So what I learned in the All India Institute was a foundation for my surgical career, and the first thing that I learned was the academic program has to be the backbone of any professional or surgical career, and they had a very strong academic program. Most of the classes or the sessions used to be done by the residents, and we used to prepare on those overhead projection screens. We used to write in the night with sketch pens and then project on OHPs, and that's how we did the classes. We used to go to libraries, the BB Dikshit and the NML library, to collect a lot of literature. During that time there was no internet, there was no Medline, there was no PubMed. So we used to collect a lot of literature and then present our seminars. So that was a beautiful learning for me, how you could go deep into one particular area and learn about that aspect. The other thing that I learned was the sheer hard work. It was grinding. It was very difficult. I thought I'd never done such hard work even before my MS, but why do I need to do it after my MS? But there was this very beautiful saying in the seminar room which we used to read every day, saying that winners don't quit and quitters don't win. So that used to keep us there in the department always, and we had a wonderful time. I think that was the foundation of my career.
A word about Dr. Nandi.
Dr. Nandi is a phenomenal teacher. He is a great clinician. He is a great academician, and he used to be a kind of a father figure for all of us. He was a very considerate man, very upright, very balanced, and he used to, the greatest gift that he did was this department and a structured training. There was a resident's manual, how a resident, even if he is operating, how he has to take knots, sutures. Each step was standardized completely, and that has been passed on through generations and years together now, so that the residents do this thing in the same particular way. I think that structured training approach was something, is the greatest gift of Professor Nandi.
Then you moved to Sanjay Gandhi. How did it happen?
Yeah, so as I said, I used to give all these competitive exams, and my ultimate goal was to get into SCPGI because MCH was my goal. And fortunately for me, the second time I gave my SCPGI entrance, I cleared the entrance, and there were 2 seats, and I was selected for that seat. So this was like a great opportunity for me, and like a dream come true. So SCPGI was also a fabulous environment to work. Very residents friendly environment because the residents accommodation was very nice, the campus was beautiful, the department was very good. It was a much larger department, quite a high workload. The other advantage is that they were doing more of laparoscopic cholecystectomies, where we used to get some exposure to, because laparoscopic surgery had just started by that time, 92, 93. So they used to do a lot of almost 200 every year. And most of those, North Indian gallbladders were quite difficult, thick-walled, contracted. So we got a good grounding and a basic training for laparoscopic surgery in terms of laparoscopic cholecystectomies during these 3 years of my training at Lucknow. Even in Lucknow, the academic program was very strong. The department was very, very cohesive. Professor Kaushik used to keep everybody together. Dr. Vinay Kapoor and Dr. Rajan Saxena and the other faculties, Dr. Sadiq Sikara, were fantastic. They were all had their own individual strengths in their areas, in which we could learn a lot from them. All the residents were all very, very competitive, very enthusiastic. Almost 10 MCH residents were there in the department at that time. So we had a fantastic time interacting and learning from each other. So I think that those were the best years for my training.
Now, after MCH, then what next? How did you, because once again you must be in the post-MS situation as to whether to continue in this sort of a professional teaching career or go back home. If you had to go back home, I think, I had faced that. Most people, when they come and study in these central institutions, they'll be in cloud 9. But the minute it's over, you don't know what to do next.
To do, that's true.
If you go back to your home, nobody will recognize
you. Yes.
Did you face any such
dilemma? So when I finished MCH, I had a very clear goal that I have to go back to my parent, city, that is Ahmedabad. So that was very clear right during my MCH tenure. And my another goal was that I'll most likely go into a practice, because there were no academic institutions where we could have a full-time job. There were no corporate hospitals who could give us a job. So there was no other option for us but to start an individual practice. My only hesitation was that I did not have any international exposure, foreign education until that time. So that was the only thing that was in my mind. But then at that point of time, the family was a priority. And we thought that, I could, maybe after 3 or 4 years of practice, I could go and take some international exposure and go for training abroad to the other centers. So when I finished MCH, I came back to Ahmedabad and I started a small nursing home, which was like a 5-bedded, 2,000 square feet place I took up. And then I started the hospital. I was affiliated to 2 other hospitals. One was a teaching hospital that I graduated from, and another was a trust hospital that I used to go at that point of time.
But when you come back, I think you need to have real guts to start something independently in GI surgery and also operate independently, because there are a lot of senior general surgeons who don't want anybody of this nature to, to really get recognized as a GI. Was it any difficulty? Because I remember when I went from Delhi to Tirupati swims, all the cases we used to see used to be secondary liver.
Yeah.
And I didn't know what to do.
Yeah.
I mean, was there any...
Yeah, there was a big challenge. Actually, laparoscopic surgery and GI surgery was not at all established at that point of time. That was the year 1997, January, when I came back to Ahmedabad. A lot of general surgeons had a lot of opposition to GI surgery, but there were very few GI surgeons at that point of time. So there was no awareness. That was number one. Number two, there were very few even medical gastroenterologists. Number three, laparoscopic surgery was also in a initial period, and a lot of general surgeons had not picked up laparoscopic surgery. So they were like, दूरबीन से कैसे कर सकते हैं, आधा रह जाएगा. Patients also were explained in terms of how you could do it with a laparoscopic method. So there were several challenges. I think when I go back, I decided that we have to make our rules of the game and we have to stick to it. So the first thing that I decided was that I'm not going to go out and operate in individual nursing homes, which was kind of a practice at that time prevalent, that you go to some other surgeon, he will admit a big case which he is not able to do, and he'll call a specialist surgeon and then you go and operate. So the first thing I decided, whatever is the waiting time for me, I'm not going to indulge into that kind of practice. The second thing I decided was that I'm not going to indulge in any kind of an unethical commission-based practice. I will do a completely ethical practice. So these are the two things I decided, and I've stick to it. So then what I did was I was just operating at 3 places, and I felt that the best way to create awareness, and maybe you can call it marketing or awareness or whatever, is to get into the academic program, which was always close to my heart. And so we started a lot of academic activities, organizing meetings, conferences, getting surgeons, making them aware of what kind of work we were doing. And that I thought was the only way we could show that how we are different from the general surgeons, GI surgeons. What is the difference? Unless a person visits a department of GI surgery, he won't understand. Even today when we get fellows from general surgery departments, they don't understand what is the difference unless they get into a GI surgery department, and then they know what is the kind of the difference between the GI surgery and the general surgeries. Of course, at that point of time, those lines were quite blurred, and it was a challenge, but I think the academic program, the training programs, the educational activities that we kept on doing, some awareness activities, doing some CMEs all the time, it did help in a way to develop the specialty and develop us as a professional as well.
No, you said you started a small 5-bedded nursing home of your own, but isn't it that advanced GI surgery will require an intensive care unit and round-the-clock anesthesiologists, and sometimes you need help from another 1 or 2 surgeons, because many individual surgeons I see, especially Chennai, passing out and going alone on their own. I think if there are 2 people together can do a much bigger an operation or a sicker patient than did you come across that situation?
I agree, Radha, with you. At this point of time, it is different. At that point of time, it was different because in 97, there wasn't very good critical care also available, number one. Number two, fortunately for me, in the same premises that I had my nursing home, there was a general ICU on the top floor for all the medical practitioners of Ahmedabad. So I could utilize that facility whenever I needed to use it. And in my small nursing home, fortunately for me, I could do very major cases. I had done several Whipples, esophagus, shunts, pouches, ulcerative colitis in that small nursing home, which now I feel how it would have been possible, but we could do that fortunately. And of course, over a period of time, I did realize my other goal was to develop a GI specialty center. So that was always in my mind, that to develop into a one dedicated center where everything under one roof we can offer to the patient. Patient doesn't have to go out. So it should be a combined medical and a surgical gastroenterologist driven GI surgical center. That was the goal right from the time that I was in Lucknow, because I had seen there how medical gastroenterology and surgical gastroenterology, they used to coexist on the same floor. They had their wards, and how they used to interact with each other. So that I felt was a better way of giving good patient care, and that's how we were always thinking of developing this kind of a GI center.
See, I remember you're telling me once that you need to have a niche area, that you have to take up one subspecialty to become known. You can't be a generalist.
Right.
I am a generalist, but you took up colorectal as a specialty. Of course, laparoscopy is the other one.
Yeah.
You agree, but how did you come into that colorectal? Why? How
Yeah.
did you choose that?
So I think that is also by chance that how I landed up. And I'm not saying that I do colorectal, but predominant. I'm invited in most lab colorectal meetings. I have done a lot of seminars. I've done the national conference. I'm also writing a book on lab colorectal surgery at the moment. But how I landed up in colorectal surgery was completely by not by design but by default, I would say. So what happened is that in 2000, I remember from 97 to 2000, I was just doing basic laparoscopic surgery, means only gallbladders and appendix. That's all I used to do. I did not do any advanced laparoscopic surgery because I was not trained. But in 2000, what happened is that in the May of 2000, there was a World Congress in Singapore, which I happened to go and attend. And there I saw a lot of advanced lab surgeries done by surgeons all around the world. And I thought, oh wow, we do this open, we can do this laparoscopic, why not? So we decided that we will get into the advanced laparoscopy field. It was a challenge in my small nursing home to do all these new procedures, and to learn everything from a scratch was a challenge, but we took it up that we will do it. Fortunately, one of my colleagues joined hands with me, so he used to come and assist me for all surgeries. And I think it's very important when you comes to advanced laparoscopy that you have a nice, good colleague who gels well with you and washes up and bees with you all the time. So then we started, and then we had initial hiccups, difficulties. So in 2000, and we spent 1 week with Dr. Pallivelu at his old hospital. Of course, GEM was not even built at that time. So that was his Vedanayagam hospital, where he used to work with Dr. Parthasarathy, Dr. Rajan and Dr. Sendil. So I spent 1 week with him, and I learned a lot of tricks, 30-degree telescope, how to handle suturing skills. Then we learned hernia surgeries over there. We learned fundoplications. So all these helped us to develop more and more advanced surgeries. And then once we were proficient in suturing, and then the learning was quite rapid. In the year 2001-2, I had done, by that time, I had done a laparoscopic total gastrectomy, a laparoscopic assisted shunt surgery by 2003. So then 2003, we organized a very big conference in Ahmedabad with 3 days of live advanced laparoscopic surgery. We called in about 8 international faculties, and that was called the MAS 2003. So that was very well taken. Then the new hospital started, which was called the Sterling Hospital, which was a corporate hospital where I got affiliated. So there we had better equipments like a harmonic scalpel. We had a high definition, not high definition, but at that time it was a 3-chip camera. So that is how. And then in 2006, by chance, one of my friends in Pune told me that one very good colorectal surgeon, Dr. Choi, is coming from Korea. So why don't you come for this meeting? I said, I'm not interested. He said, why don't you come? He's a very good lab colorectal surgeon. So I said, okay. So in 2006, I went to Pune and met Dr. Choi and saw the way he was operating, and I loved it. And I decided to visit him. In 2006, I went to Seoul, Korea during the ELSA. I attended the meeting and spent 1 week with Dr. Choi in Daegu. And there we learned the intricacies of laparoscopic colorectal surgery. That was a fabulous experience. And then I came back and started doing more and more lab colorectal. That was a time when the COST trial had come, and that fear of doing colorectal cancer was no more there. So we started more and more lab colorectal cases. In 2007, I organized the All India ECRSICON, the colorectal meeting in Ahmedabad, and invited Dr. Choi from Korea. And at that time, we released a DVD atlas of laparoscopic surgery, which was 8 DVDs and 42 procedures done and edited on a high definition video. So that was the academic programs that we used to do, because I had 2 other surgeons affiliated with me, and we could do a lot of other academic activities. We used to do small courses for surgeons. Those were called the lab skills courses. They used to come. I developed an education foundation called the Haribakthi Education Foundation. We came out with the first book on surgical gastroenterology during that time, 2005, 2006.
How did you catch up on the idea of making a video atlas, rather the video collection? Because I bought those videos. They're quite complicated to carry, actually. There's so many of them.
Yeah.
We used to, and actually a lot of, I should confess here that a lot of laparoscopic surgery I learned from those videos. That was in
2007 was it
Seven.
when it was released.
How? And they're done very professionally at
Yeah.
very high quality, and the animation was very good. I wondered where you got all this from.
Yes.
Ahmedabad had all this help.
Yeah, fortunately we had this help. In 2006 only I had purchased a high definition camera, and when I saw for the first time a high definition vision, that was the 1088 by Stryker, it was like amazing. Wow, what is a vision? And with that we purchased a high definition recorder, which
Okay.
was called, they had a high definition recorder along with it. And then we got hired some professionals who did the video editing for us.
Okay.
And one of my colleagues, Dr. Harshad Soni, he edited all the videos himself,
Really?
sitting there. So we could collect that and collate that into a kind of a DVD atlas. And that was very well received at that time. But now I think the time have changed. The second edition we are just releasing now. Those are 110 videos. These are professionally edited, but they'll be online.
Okay.
Rather than having a DVD, because then you can see it from anywhere, even from your phone.
Right.
So I think the time has changed now.
You by then you become very busy surgeon, and where do you have the time for the book? And I know all of you must be aware of Sanjiv Haribhakti's textbook Surgical Gastroenterology, but that's a humongous effort.
Yeah. So, but I would.
Who inspired you to get into that?
I don't think there's any one thing that inspired me, but I always wanted to make kind of products or projects which are everlasting. They would be lasting even if though I or our team or people are not there. That legacy would be would continue, kind of a approach that I had. So I always like to record all the cases properly, edit the videos and put it up so that it could be archived. And for the books, I mean, I must thank all the authors who have contributed onto the book, because otherwise this humongous task is not just possible. So it was more like a collaborative efforts by all the surgeons. One of them was you, who contributed onto you have contributed onto the book, and all these friends have been very nice, so they have contributed. Of course, it's a difficult task because everybody is so busy to get the chapters in time, to edit them. It does take a time, efforts. But then unless we put in that extra energy or extra time, I don't think anything materializes. And these are things which help a lot of people, a lot of surgeons, not only in India but even outside in Nepal and other places have told me that they have been able to learn laparoscopy, advanced laparoscopy, by looking at those videos. I think that's the main driving force for me, that people utilizing those, learning and getting on, because I remember in the early years the stumbling blocks were huge. We didn't have books even to learn a laparoscopic fundoplication. I remember how to hold a stomach. I didn't know, because there were no books. There was only one manual of Sage's manual.
That's right.
Through which we used to read, and early 2000 there was nothing which we could we didn't have any standardization. So people like Dr. Palli Velu, Dr. Nageshwar Reddy are the people who have been sources of inspiration, because they used to go to these meetings and showcase this kind of procedures, and they have been a source of inspiration for us.
When and why did you think that you should have a bigger GI center? What made you think on those lines?
Yeah, so I was very happy working in a corporate hospital for 10 years. That was called the Sterling Hospital. It's in Ahmedabad, multi-specialty hospital.
DNB.
Yeah, we also started DNB way back in 2006.
Right.
DNB in GI surgery, and we had good students. We had a very nice time, good infrastructure, everything. However, I always felt that GI surgery is still a very nascent specialty. It needs to be developed well. It needs to be kind of pampered or kind of focused, so that it develops well as a specialty. And in a multi-speciality environment, GI surgery I felt was not given the due deserving credit that it always deserves. Always the cardiac surgery always is more glorified branch, a more revenue earning branch for the organization. So it's always given more focus. And GI was kind of, okay. I mean, that was a kind of the attitude, and which I never liked. I always felt that GI should get the due credit, and that's how we decided to develop a GI center of our own. So that was a group of doctors. We got together, about 4 GI surgeons getting together, and we started in the year 2008. We purchased the land and in the year 2010 we started the construction. 2011 we commissioned the hospital. So next month our hospital will be 8 years old. It is going to complete 8 years. It's called the Kaizen Hospital. It's a GI specialty center. It was named after a philosophy of Japanese philosophy which I used to love. Kaizen. Kaizen means continuous improvement. So in all our professional endeavors, what we do is keep learning, keep improving, keep doing something better than what we have done earlier. So that is something that we have started imbibing even in Kaizen Hospital in several areas, not just medical areas, but even administrative part and other areas we have started imbibing that philosophy.
Now, then you got into research or innovation. I mean, a person, see, I always felt that a great clinician is never a great administrator. Administering the hospital, did it take a chunk of your enthusiasm in the clinical medicine as such?
Yeah, so initial years of setting up the hospital, you need to devote quite a bit of time for the administration. Fortunately, we are a group of about 4 or 5 surgeons. My wife also has helped me a lot in the the administration part of the hospital, though she is also a professional and neuro-ophthalmologist working. So fortunately, we had divided the admin part amongst us, 3 or 4 people. So who would look after? Somebody would look after the finance, somebody looks after the business development part, somebody looks after the HR and the operations. So I had to overall look, because of the of the pressures of the clinical work. I was overall looking after the admin. Initially, yes, to develop the policies when we were going for NABH, a lot of inputs and involvement and energy my time used to be taken away for this kind of work. But over a period of time, once everything becomes more streamlined and there are people in place, there are policies and protocols and structure in place, then I think now the administration time is hardly anything that I spend for administering, unless there is a new policy to be made or some big dispute to be cleared. I don't have to get involved in the day-to-day operations, because we have very good managers fortunately working. And the best part of the small infrastructure that we have is everybody works like a family. It's not like a typical corporate hospital, but here everybody works more like family. The patients are also treated as such, and they also give a very good feedback that they have been very happy that the staff has treated them very well. So fortunately, it has worked out very well for us. Our team has been the same. We have been adding people to our team, and I think getting the right team together is the crux of the matter. And in today's world, I think when we are on one side the corporate hospitals and on the other side the doctors, I think if we really want to develop something, we have to get together, and we have to get the best of the professional management in place. We have to learn from the corporate hospitals how they do professional management. But at the same time, as doctors, our driving force is not primarily the bottom lines or the profits. Our driving force is our patient care. So for that, if you need a very good equipment, you don't have to convince somebody else that you need this equipment. You don't have to prove the cost effectiveness of that equipment. Of course, that rational commercial angle has to be looked into. At the same time, you are not answerable to someone. So that's the best part of having your own setup. Of course, there are pluses and minuses of each way of working, whether it is private practice, individual practice, group practice, doctors promoted hospital, corporate hospital, trust hospitals, government hospitals. Every practice has its own plus and minus. You have to look into it what best suits you. Sometimes some people don't want to do any admin, and they feel that I'm just happy doing my clinical work. I don't want to do any admin. For them, probably a corporate hospital is a good place, that you come in the morning, do your work, and go home in the evening. You don't have to manage or do administration. There are people like me who take this up as a challenge to learn. So in the process of so many years as an entrepreneur, we bought a land. I learned so much about land laws, how it is passed, how the corporation works, how the construction works, because I used to go every day to the construction site. I learned what is NABH, what are the standards and practices of NABH. I learned about finance, I learned about marketing, I learned about a lot of other things which I would otherwise have never learned. I learned about publishing a book, I learned about creating video atlases, and I see this as a learning process, as an evolution process in the in a journey of a human being, how you can learn from different, because in our medical career, somehow we are so narrowed down and tunneled. We kind of have a very narrow vision. We can only look at our specialty and we don't have much idea about the rest of the things. So this is an opportunity to, learn more and more areas and becoming a more fulfilling kind of.
Now, I haven't heard of anyone who's sort of, top class clinician, top class administrator trying to do research at that level. And isn't that, what does it fetch you?
That's a very good question, Radha. So I would say my innovation, I'll just give you one example going back to the All India days, All India Institute days, that what was that brush with the innovation. And the brush with the innovation was once I saw a notice board that there was written that today evening 6 o'clock there is this talk by Professor Abdul Kalam. At that time he was a scientific advisor to the Prime Minister, and we all knew him as a missile man of the country. And he was talking on a topic called "Why are we so utterly cubicled?" And the topic itself ignited me, kind of, what is he talking about? What is the topic? I went to just listen to what is this topic about. Why are we so utterly cubicled? And I didn't understand what it means. So I thought, let me go and see what he has to say about it. It was a small classroom. There were about 30-35 students. And Professor Abdul Kalam came and he talked about the defense, the research in the defense, DRDO, and the kind of materials that they've developed and how they've used the spin-offs of this technology, how they are created or used this carbon and other materials to create mitral valves and valve replacements, so composite fibers and things like that. So that was the first brush of innovation. And then, I thought about a new instrument in the All India Institute to go around the vessel to tie the knot. Normally we have to go twice around the vessel. So I designed one simple instrument which goes just once and takes both the threads and ties the knot, because we used to do a lot of tying at that time in portal hypertension surgery, I remember. But that never saw the light of the day. And subsequently in the SGPGI, as residents we used to hold retractors for many years. I had to do this. I couldn't see what is happening inside. They were doing hepaticojejunostomy. As a first year resident, I used to just hold retractors and standing there. For many years, we all have done that. And then I felt, why do I need to hold the retractor? Why can't there be a system where the retractors are not held in place? So we designed a table-mounted retractor system, which is fortunately has come to reality, is used by many institutions. It's known as Haribakthi retractor system for open abdominal surgery. And then we developed one hammock retractor, that is for the atraumatic retraction in laparoscopic surgery for the left lobe of the liver. So that's a scarless retractor, which I have presented at China and a lot of other conferences. And subsequently, our innovations is focused on two areas. Primarily, it was in 2016, about 3 years ago, that I had gone to learn transanal surgery by a lady called Dr. Patricia Silla. She is a very prolific surgeon. She is one of the pioneers in the field. She has published the first transanal TME way back in 2010, and she works in the Mount Sinai Hospital, New York. So I spent a week with her to learn transanal TME. And during this, I was always thinking that if you could do these kind of procedures with a rigid port, why can't you do transoral surgeries with this kind of rigid ports? That was a question that came to me. And when I came back, I decided that I want to pursue this thought, this idea. I want to expand that and see whether it is really feasible doing it. So we embarked on this project of creating some prototypes. We went to animal labs. We did some long, narrow tubes, put it into animals and saw if we could do some kind of surgery by this. Unfortunately, we could do, though it was very difficult. So we developed second, third, and the fourth generation prototypes. So currently, we are developing an endoscopic suture device. So we are working on transoral approach, natural orifice surgery, but using very different ports than what you are regularly using right now with the flexible endoscopy system. Our ports are very different. So currently we are, in the animal lab, we are doing fundoplication, gastroplication for bariatric surgery, a cardiomyotomy for achalasia cardia. These are the surgeries that we are doing from the transoral approach with the ports that we have created. So in the animal tissue, it is possible. So then we tried out in the human cadavers. going to the MS Ramaiah hospital in Bangalore, and we did some procedures on the human cadavers, and it was feasible. So feasibility of this technique is established. Now we have to use more and more, do more safety trials and other clinical trials. We are also developing a novel indigenous endoscopic suturing device which can take sutures. Currently we have a grant from the government, a 10 lakhs grant from the government to develop this suturing device. So we have hired an engineer who is working full time, is a mechanical engineer working on this device. Of course, during this process I've learned a lot about how patents work, how the copyrights work, what are the patent laws, because we have filed international patents for these kind of devices. And so that is one area, natural orifice surgery, that fascinates me. I firmly believe that this is the future of surgery. This is how many procedures will be done in the future. It is up to us to determine how we can do it. What would be the access devices, what would be the products or prototypes, and how we'll access them, and what will be the technologies which will be used to do the procedures. But this is, according to me, is one very fascinating area for anybody who is interested in this field.
So life has come a full circle. I remember you're talking about your marathon running some time ago.
Yes,
how did you get into marathon running?
That was many years ago. I think that was about five or 6 years ago that we did a marathon. But since then I've stopped running and jogging.
Okay.
I think the busy clinical practice, these are some things which we never discuss. But I think the ergonomics of a surgeon is something which is very important. Surgeon's life, the professional life, is very taxing, and it does take a toll. I myself faced many of the health hazards. It started with the cervical spondylosis, it started with back pains, it started with hip joint issues, and then I had this plantar fasciitis, for which I have to leave jogging and running.
Yeah, okay.
So it went on for almost 2 to 3 years, and sometimes it makes even the procedures and the surgeries difficult for you. You have to use different soles and different shoes and different postures and things like that. But I think that what I have now used to do is regular exercise, some kind of yoga, meditation, some regular workouts, keeping fit yourself, because the yogic exercises, especially the Surya Namaskars and the other exercises, are excellent for the spine. They cause a good extension of the spine. They're very good for the spine. You also need some kind of flexibility. So yogic asanas give a very good flexibility, because we operate in one position for a long period of time, and it gives a very big strain, especially laparoscopic surgery. It's a very awkward posture when you are operating with from two sides, constantly doing for advanced procedures. It is really taxing on a surgeon, and that's how I'm getting into more. I've written a chapter on surgical ergonomics in this book this time, because I feel that it's very important, and that's why I feel that surgical robotics does need to come in to improve the ergonomics of the surgeon. The biggest advantage currently of using a robotic system is the surgical ergonomics. So and in the future I'm sure better and better systems, more miniaturized systems and much easier systems will come up in the market, which will help the surgeon to reduce his strain and the stress of doing the procedure. Maybe you're doing a Whipple operation, but you're comfortably sitting on a console doing a 4, 5, 6 hour surgery, then you're not strained. If you are just standing and doing a lap Whipple for 7, 8 hours, it's very, very strenuous to do this kind of procedures. So I think we are all discussing and talking about patient safety, but we also need to talk about the surgeon safety part and surgeon's health part, which also needs some kind of a focus.
Where did the spirituality creep in? Because I never imagined that you'll go deep into spirituality.
Radha, I think you are more spiritual than me. He has a phenomenal collection of spirits in his room that is unbelievable, and he's one person who is away from the spirits. He has never tested it and never uses it. So I think you are much more spiritual. And his better half, Dr. Selvi, she's a phenomenal breast surgeon, but she's in a search of an eternal spirit as well. So both of this couple is an highly spiritual person, and I can't say that I'm...
What brought you into it?
Yeah, so I think spirituality is something that was always there behind, but some circumstances comes up in your life where it comes into the forefront kind of a thing. It becomes more like a priority. Always wanted to do things like this, some scriptures, because I always felt that scriptures is a big treasure that we have, we are sitting on that treasure, but we have never explored it. Kind of a feeling was always there. I always knew that meditation has a very good calming effect, but we never indulge into it because our professional lives have been very, very occupied. Our careers have been all guided by professional work. But I think there were some incidences in 2008 since some professional events which eventually took me into spirituality, guided me into spirituality, and having explored that path, I think it's a phenomenal path. The kind of the bliss that you get in that path is something which cannot be expressed. It has to be experienced. I'm sure one lifetime is very inadequate to learn more about our scriptures, but you can actually, you can decide your goal, and one can live on that path. Maybe it may take one lifetime or even more to achieve that goal, but once you are on that path, I think you see things from a different perspective. Perspective changes. You can start taking even common daily kind of incidents which happen, say between father and a children, or between husband and wife, can be looked from, or between parents and children, can be looked from a different perspective. And so it does give us a very different worldview, a different way of looking at the same thing, which in spirituality is called Pratipaksha Bhavana. You can see it from a different way, because whenever we are young, we always see, okay, medical profession is the best, surgical profession is the best, and then you do everything, you put all your energies, everything. So you just see one side, but you have never seen the other side. What is the other side of this? What is the toll that it is taking on you in terms of your other side development, on your family, your work-life balance, on your children, how it affects your other relationships? You never look at that part, So this spirituality gives you a perspective. It gives you a balance. It gives you a, it also gives you a focus. It also gives you a calming effect. You can take your decisions in a much better way. That is what I have experienced from the spirituality.
So 2 days ago, I was watching one famous Tamil hero advising another actor, saying, in our profession, it's our face and the body are important because we have to take care of this. In a surgeon's, from surgeon's perspective, what is important that he should take care of?
I think it is the ego that we need to take care of, because for the surgeons, the biggest threat is the ego. I can do this. It just takes me 15 minutes to do this. I mean, I have treated thousands of patients. I've got them well. This ego is the biggest threat to the surgeon. If we can surrender this and see ourselves as an instrument in the welfare of the patient, I think that is the biggest, contribution. And the patients can sense that as well. It's not that the patients don't sense our emotions. They also sense our emotions, because they will come and say, oh, aap to Bhagwan hai, Doctor Sahab, aapne mere ko bacha liya. Now at that point of time, what you are going to feel inside? Acha, main Bhagwan hu, maine bacha liya. Then means that I am Bhagwan, means I cannot fail. If I believe that, no, I am not the Bhagwan, I am an instrument in the hands of God, I am helping this patient, then I say, okay, I am an instrument, I can fail also. So next time when I have a failure, I am not so worried or upset about the failure. So it gives you a perspective to take your failures, because surgical career, you face complications in and out. GI surgery is one of the most complex, complicated branch, probably one of the highest morbidity and mortality in any surgical field. So we have to be grounded. We have to, surrender our ego and think that, then I always tell my patients, see, I am not God. I am a human being. I am a surgeon with whatever limited ability and knowledge that I have. I'll do my best for you. But don't expect any miracles from me. I cannot assure you any 100% guarantee of any job that I can do. You have most likely 99% he'll be fine, but you have to leave 1% to the nature, because everything we can't determine. So I clearly tell them, for all our ICU patients, critical ill patients, I think communication is another very key which we have never been taught in the medical curriculum. But communication with the patients and the relatives is such an important part to establish a trust, a bonding of trust, to establish a doctor-patient relationship, and for critical ill patients to keep that bond intact all the time, so that they have a trust in the treating doctors, to apprise them of what all we are doing, what all are the problems. So we have a counseling room which is of course under audio video surveillance because these days medical legal implications, but we every day sit down and talk about each and every patient after we see them in the ICU. I think that's very important. Just standing and talking, okay, aaj theek hai, ye theek nahi hai. We make sure that we make them sit down, we are sitting down and we are talking every day with them. So I think these are the things that I've learned along the way, which are very important to avoid these medical legal problems. I think documentation is another very important part. We should keep proper documentation wherever we have seen a patient, though it is whatever urgency, but at least a short note must be there. And our team must make sure that whenever we see, if we are not writing, at least they write that we have seen the patient and this is what we have advised. So this, I think, communication, documentation, and these are the key to, I think, reducing stress in our professional work.
Thank you so much, Sanjay. It's wonderful talking to you.
Thanks, Radha. It's such a pleasure.
There's so much I've learned, I should tell you, and hope we'll.
You are too humble, Radha. You have already surrendered your ego, but I need to do that.
We'll definitely have one more chat.
Thank you so much.
Thanks.
Such a pleasure.